So I'm here to introduce the next session, which is on the Beat PD challenge, which is a digital biomarker challenge. My name is Larson Omberg. First of all, I work at Sage Bionetworks, and I work in digital health there. This challenge that we are going to be presenting next is actually a follow-on to a challenge we ran a few years ago, which was also on digital biomarkers. This one is slightly different, though, a little bit more complicated problem to solve. And to introduce this topic and the challenge and the structure of it is going to be Solly, and then we're going to be joined by 3 of the winners and 3 of the sub-challenges. And after that, we'll have a full-on discussion. Thanks. I'll hand it over to Solly.
On behalf of the Beat PD Challenge organizers and community phase participants, I'm happy to present to you today the results of our challenge. Parkinson's disease is a neurodegenerative disease which is typified by motor symptoms, including tremor, rigidity, postural instability, lack of spontaneous movement, and freezing of gait. And these symptoms are often asymmetric and manifest quite differently from patient to patient. Additionally, over time, most patients develop complications of their treatment, which include abruptness of abrupt wearing off of the drug, as well as dyskinesias, which are quite violent movements, involuntary movements. And these symptoms can fluctuate quite a bit throughout the day, as the half-life of L-DOPA is fairly short. So a 30-minute visit with the physician is not going to really adequately represent the full lived experience of a Parkinson's patient. Sensors on watches, smartwatches and phones really provide an opportunity for us to better track symptoms throughout the day by passively monitoring patients. However, these data are complex and require algorithms in order to interpret them. In 2017, we ran the Parkinson's Disease Digital Biomarker Challenge, in which we showed that algorithms could be used to interpret these data to predict symptom severity. But this was done on short tasks, and that's still quite a long step away from passive monitoring of day-to-day living. So with that in mind, we developed the Beat PD challenge. So in contrast to PDDB, we wanted to make this challenge to use free living data at home. And we also found, through discussion with physicians, decided that we needed to make this personalized, so build personalized models in this case. We leveraged 2 data sets. Both data sets collected sensor data at home as passive monitoring. They both asked subjects to report their symptom severity at 30-minute increments over multiple days. They reported their symptoms for on-off medication, dyskinesia, and tremor, though we had to harmonize the phenotypes across the data sets because they were reported slightly differently. Both data sets wore a smartwatch, and additionally, RealPD had a an Android phone in their pant pocket. We took the sensor recordings from these data and segmented them into 20-minute non-overlapping reads, each of which corresponds to a single symptom report. We obscured the ordering of the segments because there is a lot of information in the autocorrelation of the symptom segments, as you saw from an earlier slide. If you know something about time n, you know quite a bit about time n+1. We really wanted to focus on whether the sensors themselves provided information about the symptom severity. We performed QC, filtered low activity segments, and removed subjects showing no symptom variants for a particular phenotype, as that's not interesting. We then split the data per subject into training and test split, and challenge participants were also provided minimal demographic data, as well as UPDRS clinical ratings, which is a clinical scale of disease severity. After QC and filtering, we ended up with 10 to 15 subjects for the CIS-PD data and 5 to 7 for real PD, with a mean number of segments per individual of about 150 for CIS-PD and between 60 and 70 for real PD. So we had substantially less data for real PD. We developed 3 sub-challenges to predict on-off medication status, to predict dyskinesia severity, and to predict tremor severity, so based on 3 different phenotypes. We used the mean squared error as our scoring metric. We wanted a metric that reflected the degree of misspecification, not just the misspecification of a prediction. So we used mean squared error within subject, and then we weighted across subjects using the square root of n. There was quite a range in the number of segments per individual, and so we didn't want a challenge participant to be able to win the challenge simply by focusing on the subjects with the most data. So the winning algorithms minimize this weighted mean squared error, and we also compared them to a null predictor, which is the best you can do without the sensor data, which is the mean per subject. The results of sub-challenge 1, we had 37 submissions, of which 6 statistically outperformed the null model, and the winner being Team DBMI. For sub-challenge 2, we had 38 submissions. In this case, only 3 of them statistically outperformed the null. And the winning team here was ROC Beat PD from Rochester University. And for sub-challenge 3, we had 37 submissions, of which 6 statistically outperformed the null, with the winner being Yunfang Guan from University of Michigan. And you'll hear from each of those winners following me. The challenge ended in May, and since then we've had an active community phase. We invited 6 of the top teams that showed models statistically better than the null, of which 5 participated. And we've been performing a number of really interesting analyses, of which I'm just going to give you a brief highlight because we don't have a whole lot of time. First, we wanted to look at the subjects and see if some subjects were better predicted than others. And indeed, we see quite a range in terms of whether or not a subject is predictable. There are subjects in which all of the teams are doing well. There are some subjects in which some of the teams do well, but not others. But then there are a number of subjects that are not well predicted at all. And we've done a little bit of looking at, what makes a subject predictable based on the information that we have, and found it's most closely related to disease severity. So the more severe the patient, the better the prediction. We also had some clinically labeled data for these same subjects. So we asked the community phase participants to apply their models to these clinically labeled segments to see if they recapitulate in those data. For on-off, we found that all of the models recapitulate in the clinically labeled segments, though, again, some subjects were predictable and others were not. For dyskinesia, we found largely that these models did not recapitulate in the clinician-assessed data. And for tremor, we found that some models did and some models didn't, but that wasn't necessarily related to how well the model did in the original data. So in conclusion, BEAT-PD is an important proof of concept that sensor data from free living situation contains information about symptom severity. Previous work from our challenge and from other researchers have shown that this is possible from short segments, but this was really the first of its kind to use free living data. And so while these data are really not yet, while these algorithms are not yet ready to roll out and be clinically useful, this is a really important proof of concept. We also found that the predictability is highly heterogeneous across subjects. It's most related to disease severity, but we also explored a number of other factors. For instance, we found that it's not typically related to reporting lag, which might be a proxy for how accurately a patient is reporting their symptoms. We also encouragingly find that these models recapitulate in clinically labeled tasks for the same, for some of the same subjects, which is important to know that these models are really picking up true factors related to disease. I'd like to acknowledge our organizing team out of Sage Bionetworks, Evidation, Northwestern University, Radboud University Medical Center, and in particular, Alex Mariakakis, Nick Sean, who were instrumental in the pre-challenge vetting of the data and analysis, and Phil Snyder, who implemented all of the framework for scoring the data. I'd also like to acknowledge our community phase participants from Team DBMI, Hapraz Dor, Heki, Rockbeat PD, and Yanfeng Guan. And of course, our funders from Michael J. Fox Foundation, who've been a strong proponent of open science and open data, and our data hosting partners for this challenge, which is Brain Commons. Thank you for your attention.